Let's continue with chapter 17. It's not going to be the entire chapter. The testable part here is the how to manage transplant rejection. Let's understand the concept first. So how does the body, particularly your immune system, recognize self from non-self? Each cell, whether it's ours or another person's cell, or bacteria, viruses, fungal organisms, all cells have protein receptors on the cell surface, meaning this gives you your unique ID, your unique identity. So let's say Miss Bulger, for instance, Miss Bulger's cells have a unique protein ID. All the cells in her body has the same protein ID on the cell surface. So as her immune system cells bump into another cell in the body, as they traveling throughout every cell, every tissue, every organ, it's easy to identify self from non-self because if they bump into them, the membrane proteins match, so they identify each other. Okay, yeah, yourself. And then it's only when they encounter somebody, a cell or a tissue that is not going to match, then the immune system will be triggered. So as they encounter these in the bloodstream, for instance, as they are circulating, that's where you identify self from non-self. Okay, and then the sequence is inflammatory cytokines have to be activated first. I'll just go through these because these are all nice to know. I'll go straight to the cytokines. Before that, by the way, the patient's total WBC count is 20,000. What is the normal total WBC count?
5 to 10,000.
Okay, 5 to 10,000 or 6 to 10,000 in other books. If your total white blood cell count is 20,000, what does that mean?
Infection.
My next question is, what type of infection is the patient having, if any?
You mean like whether it's local or systolic?
No. Okay, to help you answer that is, we really don't know, because there are different types of white blood cells. One of them are neutrophils, which we talked about bandemia earlier. We know neutrophils are, their only function is to fight bacteria. The next group are, and they're written here, by the way. So here, bacteria, okay, they're in the paragraph. So when you have bacterial invasion, neutrophils are the white blood cells that are activated. So here's the left shift in bandemia. So this is the breakdown of your white blood cells. So when we have a total WBC count, so let's say 10,000, a normal or a regular CBC, a complete blood count, won't give you this breakdown. This is not available. So all you have is the total white blood cell count. Is that it doesn't tell you what is it made of. When we have a differential now, the doctor orders the CBC with differential count, then the lab scientist will now count what is this 10,000 total composed of. So it is now expressed in percentage. If you add all these, this will total 100%. This is the normal distribution. It's also mentioned here Neutrophils make up about between 55 and 70% of your total white blood cell count. That's normal distribution. However, there are two types of neutrophils, as we mentioned before the break. So there are segmented neutrophils, which are the mature ones, and then we have immature neutrophils, which are bands. Bands should only compose 5%, and the mature ones 50 to 62. In the case of a bacterial infection, meaning the patient is already overwhelmed by the infection because you now have manifestations of the infection, this will now increase because at this point, if the patient is already overwhelmed, the bone marrow cannot keep up with the blood cell production. So therefore, what the bone marrow will do is just release whatever it's got. So even if the neutrophils aren't ready yet, they will release them into the bloodstream because of the presence of infection. Hence, you have a high count of band neutrophils as compared to segmented neutrophils, meaning is your body winning or losing the battle?
Losing.
It's losing the battle because now it's sending children out to the battle, into the battlefield. All right, so that's your indication that the patient is fighting, or at least trying to fight an infection with children, right? With banned neutrophils. So that's neutrophils. These are neutrophils, and then the other types of white blood cells are monos, lymphocytes, monophils, lymphocytes, eosinophils, and basophils. So those are the others. Each of them have a different function. Look at here, for instance, basophils. What are they used for? When are they activated? In what type of infection?
Antibodies.
Yeah, it's not even an infection. They are activated by allergies. So if you have an allergic reaction, basophils will increase. What about eos? Eosinophils increase when you're attacked by what?
Parasite.
Okay, and so on. So here, that's eos. We looked at basos, eos. And where are monos? Monos must be mentioned somewhere here. We missed it. Anyway, monos are usually viral, okay, along with lymphocytes. Lymphocytes are your viral fighting white blood cells. Okay. Well, there's two types of lymphocytes. We have T and B lymphocytes. So it really depends which lymphocyte we're talking about. So your T cells are your major disease fighting. They are also known as your natural killer cells. So they are the your best soldiers. Okay. So that was just an introduction in relation to how it fits now to organ rejection. So the next testable part here is the cytokines. Because as I mentioned, before the white blood cells are even activated, something has to activate them first. So here are your inflammatory cytokines. So let's say you have an invader. So a virus, a bacteria, whatever entered your bloodstream. So now you have cytokines will be the first to be activated. So they are inflammatory cytokines. There are a lot of them, table 17-4. So this pro-inflammatory cytokines, there are a lot. So these are just the pro-inflammatory ones. So we have interleukins 1, 2, 6, and tumor necrosis factor. So these four guys here are responsible for stimulating your immune system. Look at the function of interleukin 1. Induces fever, stimulates prostaglandins. Prostaglandins are vasodilators, so they help increase blood flow to the area where there is an invasion and increases the growth of CD4 plus cells. Interleukin 2 T lymphocytes and enhances natural killer cells against cancer cells because our immune system also fights cancer. And then interleukin 6 stimulates the liver, so this has something to do with blood clotting. And on top of that, increases bone marrow production of stem cells, therefore, it increases the production of white blood cells and increases the numbers of B lymphocytes. B lymphocytes are your um, the best description I can use is these are the intel people. They're in charge of identification, meaning in order to make antibodies, you need B lymphocytes. So the killer ones are really these T lymphocytes are your actual soldiers. And then, of course, the tumor necrosis factor. This guy here is responsible for symptoms of inflammation seen in rheumatoid arthritis, in psoriasis, in Crohn's disease. Okay, because those are autoimmune disorders. So this will make sense later when we get to the drugs because the drugs used to prevent rejection are designed to target these cytokines right here because instead of suppressing the actual lymphocytes, they will instead suppress the very cytokines that stimulate the lymphocytes. So therefore, if you suppress these guys here, these here will not happen. Does that make sense?
Yep.
Okay.
Just say
All
that
right.
one more time. I'm sorry.
Okay. So the drugs used for to prevent organ rejection are geared toward these pro-inflammatory cytokines here. So you've probably seen on commercials like TNF or tumor necrosis factor inhibitors like Humira. You've seen commercials of Humira on TV. I see it all the time. The generic name is adalimumab, and they always go. Um, Others are Stellara. Okay, those are all tumor necrosis factors inhibitors. You've probably seen the commercial that go, before starting Humira, your doctor should test you for TB or tell your doctor if you have TB or are prone to having TB.
Yeah.
All right, you've seen those commercials, right? Because these drugs, because if you inhibit tumor necrosis factor, this is the very cytokine that stimulates the immune system, stimulates your lymphocytes. So therefore, if you suppress them, what will happen to your immune function, your ability to fight infection?
It will be suppressed as well.
All right. So that's the reason why there are, but however, it's sometimes necessary to do it because, let's say in rheumatoid arthritis, for instance, or in psoriasis, all right. So sometimes it's necessary to use these drugs in order to suppress autoimmune disorders, but they are also useful when we're doing transplant because remember the TNF, I mean um, what was that? The first thing we did, the protein membrane thing. HLA, okay, human leukocyte antigens. Okay, let's go now here to organ rejection. Who needs a transplant?
People with organ failure.
All right, so what can be transplanted? So we have heart, lungs, kidneys,
Me.
liver,
Eyes.
skin, eyes, right? So we can transplant almost everything, almost, okay? Blood transfusion is actually a living transplant. Okay, that's an example of a transplant. Okay, so we're using another person's organ to donate into somebody who doesn't have that functioning organ anymore. So we have many solid organ transplants, but since remember we have different HLAs, we have different protein identification. So therefore, during cross-matching, we will have to settle with close enough, because the only exact match is if you have an identical sibling right here. Okay, so unless you have an identical sibling, then there's no one really that's an exact match. So I mean, there's no perfect match. So during the search of a donor, we will have to settle with a close enough match. All right. And then all we'll do is, because it's not an exact match, will it be recognized by the immune system as self or non-self?
Non-self.
It will always be non-self. Okay. So the only way a solid organ transplant will survive in a host is to suppress these cytokines right here, which are responsible for organ rejection, because these guys here stimulate these lymphocytes, the immune system, in order to fight an invader, which the solid organ that was transplanted is actually an invader, because it's a foreign body. Okay, it's not part of you. So it will never be accepted. So every single second of every single day, the immune system will always try to fight and kill that solid organ. So the only way we can help it survive is to suppress the cytokines. So here comes the three types of rejection now. These three types occur at different periods after the transplant. The first one, which is the most rare, is called hyperacute rejection. Now, the signs and symptoms will not be mentioned here because we're not talking about a specific organ yet. We have, let me check attendance first. Okay, thank God for screenshots, right? Hyperacute rejection. So this is the most rare, and this occurs usually within the first 24 to 48 hours of a transplant. It can occur during surgery. Good thing it's the rarest though, because of course before we decided to do the transplant surgery, we did the matching. Okay, we did months of searching or even years, and then followed when we get a match. We prepare the patient and the donor. Okay, or let's say this is a cadaver. We did the same thing. So we did careful tissue matching. We did all the tests necessary to ensure that this is a successful transplant. Okay, we suppress the recipient, the host, before we do the transplant. We wash the quote unquote, we wash the graft, which is the donor solid organ. We By washing we mean we removed all the antibodies, antigens that are possibly in there. We remove the white blood cells that are in there, because we don't want, because before we do the transplant we have to suppress the host, so it's dangerous if there are active antibodies in there, or white blood cells in there. Okay, so it's dangerous for the recipient. So we did the um, proper preparation. Okay, we did all the checks to make sure it's successful. So that's why this type of rejection is actually very rare, because we did our homework. However, it does happen occasionally. What happens is this part here that I highlighted. So there's a antigen antibody complex that we thought we already got rid of. Um, so how it rejects the organ is there are millions of small clots that form throughout the new organ. And as stated here, once there's enough clots to block all the vessels inside it, of course, there's no more perfusion because all the vessels, every capillary, artery, and vein of that solid
Well, once
organ
when
being
I leave,
is already blocked with blood clots. So of course it dies. Okay, it turns, if it happens during surgery, it turns gray, it turns ashen, and then it turns black. All right, because it's supposed to turn from pale to pink to red to functioning. Okay, that's the usual reaction. But if this happens because of the blood clot, widespread clotting that occurs, the organ dies. Somebody had a question? No, okay. So the only thing we can do is just remove the organ. The organ's gone. It's dead. It's necrotic now because it's blocked by blood clots. So we go back to status quo. We find another donor. There's nothing we can do to stop it once it's already started because it happens within hours. This one is the most common. How does it occur? Well, first place is it occurs 1 week to 3 months after transplantation, and sporadically, meaning does it occur only once?
No.
No, this will occur again and again. All you can do is just stop it every time it happens. There are two mechanisms involved here. Unlike in hyperacute rejection where the cause was clotting, this one is not clotting. This is two. One is vasculitis, meaning inflammation of the vessels of the host, of the graft. So we'll call the transplanted organ the graft, and the patient receiving it is the host. So the graft develops vasculitis, or this is inflammation, swelling of the vessels, but not clotting. Okay. So once the vessels are inflamed, of course, that narrows the lumen and then will reduce blood flow to the graft. The second part, which these two are occurring simultaneously, it's cytotoxic, meaning the even though we're already suppressing the host immune system, meaning they're already taking the anti-rejection medications, the immune system found a way to fight back. So they still increase the number, and then they found their way into the graft. They tried to kill it. Of course, there's not you don't have a fully functional immune system because you're taking immunosuppressants, but they still manage to attack it somehow. So they cause some damage to the graft, but don't worry. This is not everything is lost. So there's injury to the graft, but we can still save it. As stated here, an episode of an acute rejection doesn't mean you lose the graft. We can still save it. We can still either increase here by drug management. You can either increase the amount of immunosuppressants, or you can add more medications. Okay, so and this can occur again and again. So all we can do is just monitor when this happens, careful monitoring of the patient's blood work, specific to the organ. So if this is a kidney we're talking about, we monitor kidney function. If this is a liver we're talking about, we monitor liver function, etc. Any question on acute rejection? Okay, the last one is chronic rejection. So let's review so far. Hyperacute, is there treatment for this one? Nothing. Once it forms, once it occurs, the organ's gone, we throw it away. Or put it on the grill. I don't know. I don't care what you do with it. Acute rejection. This one occurs again and again. two mechanisms. This one, the vessels become inflamed, and then there is also killer cell activity here. So all you do is increase your immunosuppression. That way you stop it from happening, and you can still save the organ. In chronic rejection, the nature here is not clotting, it's not vasculitis, it's related to chronic inflammation and scarring. So little by little here, over a period of months, years, decades, there is some slow, insidious inflammation, and then the graft is slowly replaced by scar tissue until the graft eventually is overrun with scar tissue. And of course, scar tissue is not functional tissue, and then it's gone. So it's like the organ or the graft failed all over again. So the patient ends up here with the status quo right where they started in the first place. Wherein, let's say, a patient who had diabetes, right? Had kidney damage due to the diabetes, and then they required dialysis, and then they found a donor, so they got a transplant, and then eventually they led to here. So if this happens, it's like that graft that they received failed again, and now they'll be back on the transplant list again. We can try to slow this down, but as stated here, you can't really stop it because in the first place, this occurs slowly, so slowly that you can't really. There's no way you can identify it early. Okay, so this one is so um, insidious. That's the best word. You can't really monitor it as it happens because it occurs slowly over several months, over several years. So the only way to manage this, as described here, there's no cure, but you can delay the progression. How do you delay it is to drug management again. So either um, change the drugs, add more drugs, or increase the doses. Okay, um, that's all you can do. You can just prolong the, let the graph function for as long as possible, but eventually it will be um, it'll no longer function because it's all scar tissue now. And like I said, you'll go back on the transplant list. Any question on the three types? Hello?
No, sir.
No.
All right, so the last part for tonight is the drug therapy. So we kept mentioning in acute rejection and chronic rejection that we can, in the case of acute rejection, we can stop it by adjusting the medications. In the case of chronic rejection, we can delay it. So what those drugs are in chart 17-2, page 301. So there are three groups of drug therapy here. One is corticosteroids, calcineurin inhibitors, and then finally antiproliferatives. How they work is mentioned here. So corticosteroids broadly inhibit cytokine production. And you know what those cytokines are, right? They are cytokines, interleukins 1, 2, 6, and TNF. So since they broadly inhibit cytokine production, does it say specifically which cytokine it is?
No.
No. So
No.
they inhibit all of them, resulting in generalized immunosuppression. However, since this is a corticosteroid, this is a stress hormone, what will happen to the patient? Because how long are they taking this? Only a couple months, couple weeks? This is taken for as long as the graft is in there. So therefore, long-term use of corticosteroids results in these conditions here. So let's learn a quick rationale how. So this is a corticosteroid. Everybody knows who's ever taken a steroid. For women especially, this causes fluid retention. So this will increase blood volume, leading to high blood pressure. This is a steroid, so it is stress hormones. It increases your blood sugar. You know what the body does with blood sugar, right? I mean, excess blood sugar. So if you have hyperglycemia, the excess sugar is turned into fat. Where does that fat go? Into your blood vessels and also around your waist and everywhere else. Over time, you will develop Cushing syndrome. This was discussed in chapter 62, 5th semester. We have weight gain because of the fat deposits. Weight gain also is attributed to the fluid retention causing the increased blood volume, so they are related. Because you are inhibiting the cytokines which are responsible for immune system activation, so you're at risk for common infections. And if blood volume increases causing hypertension, fluid volume in the eye will also increase, causing glaucoma. Because this is a stress hormone, it increases, you know how it is when you're under stress. What happens to your gastric acid production? You guys get heartburn, right?
Increases.
Hyperacidity. So you have the risk for GI ulcer formation. So if I turn this into an intervention question, what will be your answers? So somebody taking a steroid, the question might just be here, identify, select all that apply, which are the complications of steroids, chronic use of steroids. So these are your answers. However, if this is now turned into a, let's say, intervention or prevention question, do you know what will apply? Let's say this one, for instance, there are risks for infection. What would be your intervention for that? Or this one, what will be your intervention? They're at risk for glaucoma. What will you encourage the patient to do? Or they're at risk for this. For instance, would you tell them to avoid people with infection? Yeah?
Yeah.
Okay. Monitor their temperature. Monitor blood sugar. Take NSAIDs. No, not NSAIDs. Take H2 receptor blockers or proton pump inhibitors. Get regular eye examinations. Weigh themselves daily. Prevent falls. Okay, or take calcium supplements. Oh, we forgot to explain this one. So here, once you have increased acid production, this will now impair calcium absorption. So impaired calcium absorption now leads to low calcium in the blood and you'll have osteoporosis. Any question on steroids? Alrighty then, let's go to the next one. Calcineurin inhibitors. So this one is more specific. Calcineurin inhibitors specifically inhibit interleukin-2. And if you go up the page, what is the function of interleukin-2? Whatever it says, these are your drugs. So you have cyclosporin, tacrolimus. These are the side effects of these two drugs. So both are nephrotoxic. They mimic prednisone also. Here you also have hypertension and opportunistic infection. But remember, in interleukin-2, since this one affects the natural killer cells, which also fight cancer cells, so that's why you have malignancies here. So these patients may develop certain forms of cancer because they can't fight cancer cells anymore. You still have the hyperglycemia, hyperkalemia, and then this one specifically gingival hyperplasia. So make sure this patient does proper oral care while on this drug. Questions? Alrighty then, let's go to the last one, antiproliferative. So you have these two, mycophenolate and azathioprine. Never mind these. They're not very common. These two are the most commonly used in, at least in North America. So this is Imiran. You'll see this also taken by patients with multiple sclerosis. Cellcept is the cheaper form. This is used for most transplant patients. So the drug is an antiproliferative, so anti-proliferation. So therefore, they inhibit cell division. So they interrupt cell division by inhibiting something essential to DNA synthesis. So what cells do they affect? They will affect mostly rapidly dividing cells, and those rapidly dividing cells happen to be inside the bone marrow. So the bone marrow produces all three blood cells. So we have red blood cells, white blood cells, and your platelets. So that's why your manifestations here are thrombocytopenia, anemia, and neutropenia or leukopenia. And in the same way, because you're suppressing all three, you're also at risk for infections. And because that includes white blood cells, which are your natural killer cells also, so you have cancer also. Okay, malignancies, opportunistic infections. Nausea is included here because the lining of your GI tract from your mouth to your rectum are lined with single layer epithelium, which are constantly produced. They die constantly and are also replaced just as fast. That's why you notice you get a cracked lip. It heals overnight after you put just moisten it. The skin peels off by morning. So that's proof that your GI tract cells divide really fast. So it heals pretty fast. So they are affected. So they will be irritated, causing nausea. And that's it. This will not be on the quiz. Only chapters 14, 15, a little bit of 15, and chapter 16. Any question?